Good morning, everybody, and thank you all for being here. So we have no relevant disclosures. So for our topic, our search yielded a total of 427 abstracts, of which 80 met final inclusion criteria and were used to draft the following statements and recommendations. In total, we reviewed 14 randomized control trials, 9 systematic reviews and meta-analyses, 47 retrospective observational studies, and 10 prospective. Now, we reviewed these 80 articles and drafted 5 sets of statements and recommendations to cover the following 4 subtopics within our overall topic. So 3.1 deals with risk factors for recurrent diverticulitis, 3.2, the optimal non-operative strategies, 3.2, optimal follow-up following treatment, and 3.4, the role of interval endoscopy. So beginning with 3.1, what are the risk factors for developing recurrent diverticulitis among patients treated for uncomplicated acute diverticulitis? And our statement is as follows, that in patients successfully treated for uncomplicated diverticulitis, the most commonly reported risk factors for the development of recurrent disease are young age and a previous history with a low level of evidence. And our recommendation was that these patients should essentially be counseled regarding their elevated risk for future episodes and the possible long-term treatment implications. When reviewing the results of the survey, close to 90%, or just over 90% rather, agreed with this recommendation, and over 70% of respondents said that this was already part of their current practice. So nothing overly contentious with this statement here, so we'll move on to the next question. 3.2 again deals with the optimal non-operative strategies in the management of uncomplicated diverticulitis. There are 2 sets of statements and recommendations for this question, both of which will require revoting. So we urge you guys to listen up. So the first statement says that in immunocompetent individuals presenting with uncomplicated acute diverticulitis, symptomatic treatment without antibiotics provides similar outcomes to treatment with antibiotics, with a high level of evidence. And our recommendation is that of a weak recommendation that a trial of non-antibiotic therapy can be considered with appropriate follow-up in selected immunocompetent individuals presenting with uncomplicated acute diverticulitis. Not surprisingly, this statement and recommendation generated a bit more controversy. Under 60% of respondents agreed with the recommendation. Only 30% of respondents said that this was part of their current practice, and over 50% said that this recommendation would not change their current practice. And so we will briefly review the evidence behind this recommendation before asking you all to revote. So there were 2 randomized control trials, open label, multi-center, that evaluated the use of antibiotic therapy in the treatment of uncomplicated diverticulitis. The first study was the AVOD trial, published in 2012, which recruited patients from 10 Swedish hospitals and 1 hospital in Iceland over an 8-year period. They randomized 309 patients to no antibiotics and 314 to receive antibiotics, with roughly 40% of patients having a previous history of diverticulitis, meaning that the trial was not limited to patients presenting with a first episode. Their primary endpoint of diverticulitis complications, including perforation, abscess, or fistula, was quite low in both groups and statistically similar. Only 10 patients in the non-antibiotic group were ultimately started on antibiotics for reasons of rising CRP or persistent fever, but none of whom developed complications. And finally, there was a similar length of stay and 1-year recurrence rate and surgery rate. The Diabolo trial was published 5 years later in 2017 and recruited 528 patients from 22 Dutch centers, 262 without antibiotics and 266 received antibiotics. Their primary outcome was time to recovery, which included being discharged from hospital, tolerating a regular diet, being without pain, and the resumption of all pre-illness activities. And this was found to be pretty similar between groups statistically and clinically, 14 days versus 12 days, with similar rates of in-hospital diverticulitis complications and 6-month readmissions, ongoing diverticulitis, or recurrence and surgery. Additionally, there are 5 observational studies in support of non-antibiotic therapy. And very importantly, no study that was identified that said non-antibiotic therapy was inferior to antibiotics for the treatment of uncomplicated diverticulitis. Also important to consider is that all of these studies come out of Europe, and these findings have yet to be replicated in North America in large populations. So with that in mind, we'll ask you guys to re-vote on the high level of evidence with a weak recommendation that a trial of non-antibiotic therapy can be considered with appropriate follow-up in selected patients for uncomplicated diverticulitis.
Are you still awake?
Very much.
Good.
Okay. See? Almost 130 already.
So still just under consensus. Actually, not much change from the initial survey, so 62%. So we'll move on to the second part of the voting. So the impact on your practice.
$170.
Yeah. So 10 more seconds on the impact of this recommendation on your practice. All right, so 50%.
Consensus achieved.
So it's a stubborn crowd. All right, so we will move on, because I don't think we'd get anywhere further with this topic. All right, this is me. All right, so sticking with question 3.2, optimal non-operative strategies, the second statement says that in immunocompetent individuals presenting with uncomplicated acute diverticulitis, they may be managed in the outpatient setting with a level of evidence that was moderate. And our recommendation was a weak recommendation that immunocompetent individuals presenting with uncomplicated acute diverticulitis and mild symptoms may be managed in the outpatient setting. Reviewing the results of the survey, close to 90% of respondents agreed with the recommendation. 65% or so said that this was part of their current practice, but still just over 20% said that this recommendation is unlikely to change their future practice. And so we will, again, briefly review the evidence before revoting. So there was only one randomized controlled trial that has evaluated the safety of outpatient therapy for patients with uncomplicated acute diverticulitis. This was the Diver trial published in the Annals in 2014. It was a non-inferiority trial that randomized 132 patients from 5 centers in Spain to either outpatient therapy, which included a daily telephone call for 5 days after presentation, or hospital admission. And all patients, importantly, were treated with antibiotics. Their primary outcome was 60-day treatment failure, which for them meant anything from recurrence of pain or fever, or the need for readmission, intervention, or mortality from diverticulitis. And it was, again, quite similar in both groups, 4.5% in the outpatient group and 6.1% in the hospital admission group. There was also no emergency surgery in either group in the first 60 days, and no difference in quality of life at 14 or 60 days. There's an additional 5 observational studies, 2 prospective and 3 retrospective, in support of outpatient therapy. This time, a few, maybe only one, that came from North America. And again, importantly, no study has identified outpatient therapy as being inferior to hospital admission for the treatment of uncomplicated acute diverticulitis. So we will ask you guys to revote once more on the moderate level of evidence for a weak recommendation that immunocompetent individuals presenting with uncomplicated disease and mild symptoms can be managed in the outpatient setting. All right. So clear consensus that people agree with the recommendation. So we'll move on to voting with the impact that this recommendation might have on your future practice. So 5 more seconds. All right, so we have progress. We are under 20% of you who said that it would not impact your future practice, so that is an improvement from the online survey. So we'll proceed with question 3.3, the optimal follow-up following uncomplicated acute diverticulitis. We said that the use of 5-ASA agents does not prevent recurrent diverticulitis, nor does it improve chronic gastrointestinal symptoms after the successful treatment for an episode of uncomplicated diverticulitis, but that the role of rifaximin, probiotics, and fiber is less well defined, with a high level of evidence. And our expert group rated this high level of evidence with a strong recommendation against the use of 5-ASA to prevent diverticulitis recurrence or improve chronic GI symptoms among patients treated successfully for diverticulitis. The consensus was achieved on the online survey with over 95% of respondents agreeing with the recommendation, and 75% of respondents said that this was already part of their current practice. And so consensus was achieved here, and we will move on to the last topic for question 3.4, which is the role of interval endoscopy following an episode of diverticulitis. And this last question will also require revoting. So the statement reads that in the absence of high-risk features, the detection rate for advanced adenomas or malignant lesions with colonic evaluation after an episode of uncomplicated acute diverticulitis is very low, with a moderate level of evidence. And the recommendation is a weak recommendation for routine colonic evaluation after successfully treated uncomplicated acute diverticulitis, unless high-risk features are present. Over 70% of respondents agreed with the recommendation, but only 50% said that this was part of their current practice, and over 30% said that this recommendation would not change their future practice. And so we will briefly review the evidence one more time before revoting on this last recommendation. So unfortunately, unlike the issues regarding antibiotics and hospital admission, there is no high-level randomized control trial data evaluating the use of colonic evaluation after an episode of diverticulitis. But there is pretty compelling evidence that perhaps it's not routinely necessary. The best summary of the data probably comes from the systematic review published by Sharma and colleagues out of New Zealand in the Annals in 2014. They identified 11 studies from 7 countries with a pooled population of 1,970 patients. And they identified a pooled proportional estimate of malignancy of 1.6%. Now, of those 11 studies, 8 of them reported their findings with respect to disease severity. And among 1,497 patients with uncomplicated diverticulitis, the pooled estimate of malignancy was 0.7%, which is actually almost identical to the rate of invasive carcinoma picked up on screening colonoscopy in asymptomatic individuals. Now, among the 79 patients with complicated disease, albeit quite a small number, the pooled estimate of malignancy was close to 11%. Exploring some of the individual studies, these findings were echoed pretty consistently. For instance, in the AVOD trial, over 500 of those patients did undergo colonic evaluation at 6 to 8 weeks, and no cases of malignancy were found. However, other studies do identify that perhaps in certain settings with high-risk features, the rate of cancer might be higher. And so for us, we considered a high-risk feature to be anyone with complicated disease, so perforation, abscess, stricture, or fistula, anyone with ongoing or protracted symptoms that's not responding to how you would have expected, and anyone with a CT report that has suspicious findings for a mass or malignancy. And of course, this recommendation is very much contingent on getting a good quality CT scan at the time of diagnosis. So we'll ask you one last time to revote on this recommendation. I would just like to point out, before you guys revote, that when the initial survey was sent out online, the phrasing of the recommendation was felt to be a little bit ambiguous. And so we've clarified things so that it reads that this moderate level of evidence was a weak recommendation against routine colonic evaluation after successfully treated uncomplicated acute diverticulitis, unless high-risk features are present. So the recommendation is against routine colonic evaluation in the absence of high-risk features. So we'll ask you guys to vote on whether you agree with this recommendation. So 10 more seconds. Do you agree with this recommendation? Oof, just on the dot, 70%. So move on with the second part of the voting to how this will how this recommendation would impact your practice.
I want to say great job, Jillian and David. Really fantastic. Keep it up.
So split pretty evenly. All right, thank you, everybody.